Assalamu alaikum. Good morning to our morning semi. Today we'll know about pre-operative fluid management, a very important part of our daily practice. And presenter is Dr. Nazmul Hassan Saki. He is presenting for the first time in our morning semi. Let's see what he's going to do. Thank you. Be casted in first time in June.
Good morning and warm welcome to this morning session to all my respected seniors and my colleagues. And my today's topic is peri-operative fluid management. So 70 kg adult male contain 42 liter of water, that is 60% of body weight. But in case of female, that is 55%, and in case of infant, that is 75%, and in case of neonate, that is 75%, and infant, that is 75%. So 42 liter fluid in case of 70 kg adult male is divided into two parts. 66% present in intercellular space, that is 28 liter, and 33% present in extracellular space, that is 14 liter. And this 14 liter is also divided into two parts. 75% in interstitial extravascular water and 25% in intravascular water. So this chart we discussed earlier in neonate, infant, adult male and adult female, how much water contained according to body weight. So in 70 kg adult male, water approximately lost 2.5 liter by urine, feces, sweat and lung, and water gain by ingested fluid, food and metabolism. So in infant and adult, the main differences in fluid dynamics is renal output. In case of infant, renal urine output is more than twice in case of adult. In infant, urine output is 1.5 to 2 ml per kg per hour. But in case of adult, that is 0.5 ml per kg per hour. So when fluid is indicated during hypovolemia, major surgery, where fluid is being lost, or when anticipated hypotension. So types of fluid, mainly we use two types of fluid. One is crystalloid and another is colloid. But in our ICU setting, mainly we used crystalloid fluid. And the crystalloid fluids are mainly we used in ICU setting. Some are hypotonic, some are isotonic, and some are hypertonic. And half-life of crystalloid fluids are 20 to 30 minutes. So replacement of intravascular volume with crystalloid is 3 to 4 times the volume. And there are some common fluid composition we used in ICU and OT. Just see, normal saline. This term normal saline is misnomer. The actual name is normal saline is balanced salt solution. So normal saline osmolarity is 308. This is closer to plasma osmolarity. But when we use more normal saline, infusion more normal saline, then it causes hyperchloremic metabolic acidosis. So for this reason, another fluid is established. This is Ringer's lactate or Hartmann solution. In this solution, sodium is 130 millimole and chloride is 109, and potassium, calcium, and with lactate. In Ringer's lactate or Hartmann solution, lactate is used for maintaining its alkalinity, because when we use more normal saline, it causes hyperchloremic metabolic acidosis, and also the pH of normal saline is 5.5. And Hartmann solution, the pH of Hartmann solution is 7. So we have some misconception. When patient came us with AKI or AKI on CKD, we have a misconception that we don't use Hartmann solution because it has potassium, but the potassium content is only 4 millimole. And we know if 60 kg adult male daily requirement is potassium is 60 millimole per day. So we easily used Hartmann solution because of its alkalinity. Because during AKI or AKI on CKD or during CKD patient is acidic. So when we use more normal saline, it also develop more acidity. So choice of fluid is Hartmann solution. But in our cardiac setting, after operation, when patient came to our ICU, when lactate is so much high, at that time, we must be restricted to use Ringer's lactate because of presence of lactate. And during hypovolemia or during shock, lactic acidosis occur. So at that time during resuscitation period, not to use lactate, Ringer's lactate because it causes more increase of lactate. And after infusion of Ringer's lactate break down to glucose by gluconeogenesis, and then glucose bind with hydroxide and causes bicarbonate. So it produces alkalinity, but it also increases glucose level. So in diabetic patient, Ringer's lactate use must be restricted. And another misconception to use of sodium bicarb. The sodium bicarb is more hypertonic fluid than any other fluid. The tonicity is 1786 millimole. This is more than 6 times higher tonicity than normal saline. So 4 vial sodium bicarb, that means 100 ml sodium bicarb, if we used, its osmolarity is 100 ml equal to almost 300 milliosmol. So if in cardiac setting, patient's EF is 30%, and after ABT, we see base excess -3, we rapidly infused 4 vial sodium bicarb. This is only 100 ml, but it's equal to more than 500 to 600 ml water gain rapidly, and there is a chance of heart failure. In acute setting during OT, when acidosis is more, then use of sodium bicarb is okay. But in ICU setting, when acidosis occur, and if we rapidly correction by sodium bicarb, then it may harmful to our patient. Because during operation, during graft, when blood pressure is low, at that time lactic acidosis occur, and after patient came to ICU, and that time hemodynamic is stable, at first acidosis corrected in the vital organ, that means heart, kidney, and our non-vital organ is a very major portion, that is gut. And this gut portion hypoperfusion is corrected slowly after full correction of acidosis বা full correction of hemodynamic stability in the vital organ. So at that time, when more lactic acidosis, and after seeing this lactic acidosis in ABG and we use more sodium curve in ICU setting, it may harmful because of this. And the role of sodium curve is controversial because of this in our guideline. After cardiac arrest, before 2000, there is a guideline we use of more sodium curve, but now this is totally stopped to use sodium curve. Thank you. And then most commonly fluid we discussed earlier, heart salt, 0.9% normal saline. This is called balance salt solution, 5% D and TS. And some colloid we used in our cardiac OT or ICU, blood derived and synthetic. Blood derived plasma protein fraction, albumin, and synthetic component. And the fluid dynamics, the rule number 1, this is universal rule. All infused sodium remain in the ECF. It cannot enter to ICF due to sodium pump. And rule number 2 is, after infused glucose, it enter into the cell and metabolize. Then water without sodium enter both ICF and ECF in proportion in initial volume. This is clear to my next slide. How are crystalloid distribution when given I? So according to rule number 2, when 1000 ml 5% DA is infused, what happened? Total body water is 1 liter. And we discussed earlier, after infusion 1 liter of 5% DA, 66% go to the intracellularly, that is 666 ml, and 33% go to the extracellularly, that is 333 ml. And this 333 ml is divided into 2 parts. One is extravascular, that is 75%, means 250 ml, and 25%, that is 83 ml. So any kind of resuscitation, 5% DA is totally contraindicated because only 83 ml is present in intravascular. So during any type of hypovolemia, any hemorrhage, at that time, if we used 5% DA, it is more harmful to the patient because intravascularly only 83 ml present. But when we used normal saline, that is balanced salt solution, what happens? According to fluid dynamics universal rule number 1, when we infused sodium containing fluid, it can't enter into the intercellular space. So total 1 liter fluid go to the extracellular space. That is 1 liter. And this 1 liter divided into 2 parts, that means 75% go to the extravascularly, that is 750 ml, and another 25% go to the